Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Good evening and welcome. Well, it might not be evening. Welcome to our show. This is Dialogue with the Doctor, which used to be in the evening, but now it can be seen any time of day. My name is Dr. Gregory Leach. I'm a practicing physician, a family practitioner in Naples, and this is a show where we interview local physicians, not only to learn about them, but to learn about their craft, and it's very educational for our viewers and for me as well. We're here this evening, we're here with Dr. Marc Guttman. He's a practicing urologist in Naples, Florida, and we're going to talk to you about a lot of things today. But first, tell us about yourself, where you come from, where you went to school.
Absolutely. So my name is Marc Guttman. I'm from Brooklyn, New York. Wonderful place. Great pizza and bagels. And I trained at, I was at NICOM. I trained at Lenox Hill, Maimonides, went to Albert Einstein in Philadelphia, went to Sloan Kettering for a short stint, and then went back to Einstein to finish up my residency. After that, I was recruited down to Naples, and happy to be here. It's a beautiful place, and it's a wonderful place to be in practice. I won't have to move far to retire, so it's a wonderful thing. Married, have two beautiful daughters, Sabrina and Chelsea, 9 and 6. My wife Cheryl. Shout out to them.
Where can you tell us where your practice is?
Sure. So we're pretty much spread out through Naples. I have quite a few partners. We have 5 of us, and we're all over. We go to Naples downtown. We are in East Naples. My other practice is in Marco, so I kind of drive so people don't have to go too far. We also have offices. My partners go up to Bonita and a few in North Naples as well. So we try to really cover all of Naples and the surrounding areas, and we have a lot of satellite offices. So if you can't catch us on one of the main days at one of our main offices, we'll be at one of the satellites, and we try to operate. I operate at all the different hospitals that are around. So we go to NCH, we go to Physicians Regional, and that's it. So try to make everyone happy.
Who are the other physicians that are working with you?
Dr. Chan, Dr. Balandra, Dr. Wise, and Dr. Ornstein.
And now, some of those physicians, I know Dr. Ornstein, there's some, do you specialize or subspecialize?
Sure, I'm pretty much a general urologist. I try to do a little bit of everything, and we have Dr. Chan is an excellent, she does a lot of the female urology. Dr. Ornstein is an excellent robotic surgeon, so we really try to cover pretty much everything at the best of our abilities. I think it's better to have one person that does something very frequently than to have somebody that does everything once or twice a year. This way you have somebody that we really try to provide the top quality and the top, the best product available.
Well, having referred many patients to your group, I know what the quality of the work you guys do very good. So what are we going to talk about tonight?
Today we'll talk about a few updates in urology, some new things that are out there, and it's a varied topics. I'd like to start with a little bit of BPH. We'll go on to things that are just been in the news all over the place, such as prostate MRI, prostate guidance, and then different gene testing and different types of detection for prostate cancer as well. And then we'll talk about some of the other, whatever we have time to talk about in general. From a BPH standpoint, there's a lot of different.
That's a benign hypertrophy of the prostate, right?
So that's people getting up too much at night, having a little bit of hesitancy, trying to push a little bit more to go. Men, as they get older, their prostates tend to get a little bit larger, and urinary symptoms come along with that. So that's why I usually tell people, they come in their early 50s, and I tell them, and they're like, what's going on here? I'm like, women, when they're 18, they should go see a gynecologist. When men turn 50, they should, see a urologist. And, we just take care of the men's health issues and make sure everything is okay from either testosterone levels to, everything else that from across the board. So from BPH, usually what we would do is try medications first, and there's lots of different medications that are out there. I'm not going to go into that, but we do have a lot of different therapies that we start with, ranging from the weaker meds to much stronger ones. And as the medications start to fail, people start looking, or if they have side effects from the medications, people start looking for various treatment options from a surgical perspective or other treatment types. So that's pretty much what we focus on. When we talk about the surgical options, there's the gold standard is a TURP, or you could do vaporizations of the prostate now, lasers of the prostate, to try to open the canal. And as we go through different treatments, the workup includes looking inside the bladder, checking the bladder function, and the way I describe it to people is there's a pipe and there's a pump. So if you think about the pipe part of it, the medications and a lot of different things, we can use medications that focus on the pipe, that open up the prostate, relax it, and then ones that focus on the pump and relax the bladder. And the prostate would be the pipe, the pump is the bladder. So as we go through those different treatment options, the medications sometimes don't work as well as they did initially. Some people are on medications for years. Some people take a pill and they're like, I got dizzy, I'm not taking that anymore, or anything in that class. And when that happens, that's when we start focusing towards treatment.
So the TURP, which I think people have heard that name, TURP, where you transurethral resection of the prostate.
Exactly.
And that's been done for a long time.
Absolutely.
But there's different techniques or newer techniques.
Absolutely. So the newer ways to do it, the one that I prefer is called a button vaporization. There's also a green light laser. There you're opening the canal. So instead of peeing through, urinating through a hole that's very, very small, you try to make the hole larger, and it's, like I said, it's the pipe that you're trying to open up. It's plumbing. So when we do that, pretty much from a button vaporization standpoint, you can use various tools. You can use a loop to widen the canal, and you can use a little tool called a button that'll vaporize it. And the laser does the same thing. It vaporizes the tissue, and it's just different ways to an end to open up the canal. There's a newer treatment out there also now called Urolift, which we're waiting for. A lot of insurances have been on board. We're waiting for Florida to get approved for it, and it's a minimally invasive. It's something that for the younger guys that don't want any sexual side effects that can happen. You can have with a button vaporization or a green light or a TURP, you can have a risk of retrograde ejaculation. So the semen won't come out. You'll have the sensation, but nothing comes out, and various other types of things. So that's something that is preserved with this newer technology. And this is something we can show a little animation about it. Pretty much when if you look at it, the tissue on the side is the prostate tissue, and that is compressed. And what we do is we put a little scope inside the urethra, and we compress the tissue and place kind of like a little an implant, or kind of like a staple gun into it, and it opens up the canal. And what happens is, instead of the canal being tightened, like the pipe being tiny, you can see that the pipe gets enlarged, utilizing these instruments and utilizing these tools, and the implants stay in place. And if you look at the channel before and after, you can see that there's a very big difference between the compressed channel, where you'd be pushing to urinate through. This is the part where you try to urinate from the bladder. This is the part that would be blocking the flow. If you're trying to push through the before picture, it's much harder, and that's where you get hesitancy, where you feel like you have to go, but nothing's coming out. You have to push a little to get it started, and you can have all those other effects also. Your bladder ends up working very hard. It's a muscle that will get the bladder will try to work as hard as it has to get the job done. So when it does that, you get all those the urgency, frequency, gotta go symptoms also, because it's working so hard to get the urine out. To relieve that, you open up the canal, the bladder has to work less, the muscles can shrink down, and that way they don't have to push as much, and you relieve a lot of those gotta go symptoms, a lot of the frequency, urgency. And by preserving the bladder neck, the part at the top of the picture there, ejaculation and forward ejaculation is preserved. a lot of the sexual function is preserved, and that's all.
So that appears to be less traumatic just by, or faster?
It's definitely faster. It's like, 15, 20-minute procedure. And it's definitely less traumatic as well. We are still putting something into the tissue. There's 3-year data on it. At this point, since it is a novel technology, it's a new technology, and people have been doing great with it. So this is something that we're actively very, very happy about. I'm actually one of the only person at this time in Naples and Southwest Florida that's trained to do this. So I'm hoping that this is going to be one of the next great things for BPH therapy and prostate therapy.
Is it always done that way, where we saw the picture where you put 2 on each side, or how does that work?
You can put as many or as few as people need. 4 is the standard for prostate. There are some patients that cannot get that therapy if they have what's called a large median lobe or a ball valving component. If you think of it as a pipe, and then there's a little ball valve, so as the urine gets sucked in, the ball valve will seal it shut. And when it does that, when it creates that vacuum and seals it shut, you can't use something like that, because all you'll be doing is opening up the pipe, and the pipe is behind the obstruction. So there you need to do a TURP, you need to do a button, those kinds of therapies. This is more for the patients that are tired of medications, don't want to take medication anymore. They don't want to do any and they don't want a more invasive surgery. The recuperation time is less. Some people don't leave a catheter. Catheter for a day is okay also. So it is less invasive, and you have a nice open channel to go through. And if it doesn't work, you can always take that out. You can always take the staple out, and then you're done.
So when you
no
said
harm done.
When you said not approved in Florida, really, it's approved officially, but insurance isn't paying for it.
Yeah, we're waiting for insurance approval. That's pretty much it. So, but hopefully this month that won't be an issue, and hopefully by the time this airs, that won't be an issue.
Well, that's a really neat technique.
Yeah,
I like that.
It is, and it's going to be very fun to do them. I'm happy to be trained in it and to bring it out there. And this is something that's sweeping across America, and it's going to be this is going to be the next big therapy.
So how many patients, or what proportion of patients would you think would go for this technique versus the others?
This for the patients that are either young, all right, and they're on the much younger side, and they don't want any of the sexual side effects and other side effects. And then the very old, the people that really can't undergo an hour procedure or a 45-minute, hour and a half procedure to where you're resecting and you can have more bleeding and more issues like that. So those are really the people that this is really the best for. But it could be used, like I said, for any patient that's just tired of taking the medications. The medicines aren't working anymore. Side effects are an issue, and that's really where we would go for it.
Is it less effective over time? Is there a disadvantage? Or?
So far, we only have 3-year data, so I can't really tell you. But the people that I've spoken to that have gotten this 3 years ago, have all been very happy, and the people and the doctors that have been doing it from the study port, which is even before then, they said people, the results are sustained. So it's an interesting, this is going to be an interesting, therapy for BPH therapy.
Very good.
Yep. So the next thing I want to talk about is just for PSA testing and things like that. We've had last year I think I did a lecture, just like a half hour only on that. Now there's a lot of different therapies that are actually coming out now, and a lot of different testing that is done that we can say, hey, do we really need to go forward with testing? Do we not need to go testing for whether we need to do a biopsy or not? And the algorithms that have come out now are pretty much, you have a PSA test. If that becomes elevated, there's a few other tests that we have now. One's called a PHI, which is a prostate health index that we offer in our lab. That is one where it gives you a PSA, a free PSA, a Pro 2 PSA, puts it into an algorithm, and you get your risk of having prostate cancer pretty much put out there. So which is good, and that gives you an extra level. It's an updated PSA test. It's been about 30 years since they've updated the PSA, so it's about time that we've done that. The other side is to say, hey, all right, if this patient has an elevated PSA, is this something that we'd want to really look into? There's a test called 4K that's out there, and that determines whether what's this patient's risk of having an aggressive form of cancer, and that's which is also an interesting thing. So it's not really looking for the low grade stuff, but if the percentages are high that the patient would have an more aggressive form, that's where this test would come into play.
Well, we're going to take a short break, and we'll come back and talk more about PSA testing and even beyond that. We'll be back in just a minute.
Thinking of buying a home located in a golf course community in the Naples, Marco, Bonita, or Estero, Florida? Here is what Marc Lai, former PGA winner, says about Realtor Michael York of the York Real Estate Group of Downing Fry Realty.
Hi, I'm Marc Lai. If you have any real estate needs in Naples, Florida, the one company to contact is the York Real Estate Group. Also, if you want a golf course property to invest in, Michael York of the York Real Estate Group is the guy to contact. Michael knows every golf course in Naples. I will tell you this, he's been in the golf business for a long time. He's played all the great golf courses down here, and he is an outstanding realtor. I've known him for quite some time, and he's he's got a lot of integrity, and he very much knows his stuff on all the different clubs here in Naples. So the York Real Estate Group is a great place to start. So if you have any time or anybody that wants to visit down here in Naples and look at the options out there, please contact the York Real Estate Group.
Thinking of buying or selling a home in Naples, Marco, Bonita, or Estero, Florida? Think of the most experienced York Real Estate Group associated with the #1 brokerage in Naples, Downing Fry Realty, which produced $1.9 billion in sales in 2014, controlling 43% of all transactions in Naples. Jim, Michael, and Morgan York make up the York Real Estate Group of Downing Fry Realty. With over $250 million in sales transactions, they can offer you the expertise and trust you want and need in a realtor. Call them today at 239-273-6727 or visit their website, www.naplesyorkrealestate.com.
Welcome back. We just took a short break. This is Dialogue with the Doctor, and we're here this evening with Dr. Marc Guttman, a practicing urologist in Naples, Florida, and as I said a minute ago, a very good one. And we're talking now about PSA testing. Everybody knows about PSA. And I was going to say that some patients come to see me and I draw a PSA and it's elevated and I want to send them to a urologist and they're scared to go. But I try to explain to them that they need to figure out exactly what's going on, which may be not much. So you were going to talk about the PSA and testing.
Yep. So we used to give people antibiotics. We don't really do that anymore. Before, just to bring it down, unless they have symptoms, unless their cultures are positive. Now what we do is we kind of try to assess their risk. We have better tests than just maybe it'll go down with this, maybe it'll go down with that. So as I was saying before the break, there's a test called the PHI, which gives you a percentage risk. There's a test called the 4K with somebody that you're worried about that really does not want a biopsy. And you say, hey, you kind of, if you want to know what your risk of having an aggressive disease is, this is something that we should do. The other thing that we kind of talk about also is a PCA3 test. That's for a patient that's had a negative biopsy. Some people come in, they say, I've had 5 biopsies, and my PSA keeps on going up. Do I really need to get this checked anymore? And for that guy, that's where the PCA3 test was made. There, you're actually expressing some of the prostate cells. You urinate them out. We study them, send them to a lab, and it gives us a raw score that looks at looks for the PCA3 gene, and what that tells us is what the risk level is of having prostate cancer or not. So now we kind of have better tests that gives you percentages and says, hey, you have a 13% chance, a 16% chance, a 50% chance, and so on of having something there. And that's really the difference between now and just a few years ago. Let's say somebody's had multiple biopsies and they're like, all right, now we know I need a biopsy. How are you going to get the problem area? Okay. So now what we do is something a little bit different called an MRI, along with UroNav guidance. And what that does is that pretty much will tell us exactly where to go, and it can link up with our ultrasound. If you have the UroNav system, we can take the MRI pictures, link them up with our ultrasound, and watch a needle go through the suspect area. So instead of just randomly doing biopsies like we used to do, now we actually have a target, we have a place to hit. If you know, when we talk about even the MRIs, they don't find all cancers. That's not what they're meant to do. And in the best of hands and the best of people reading it, with the best tools around, they still miss a lot of the low-grade lesions. It'll miss 30% of the low intermediate grade lesions, but it finds the stuff that's bad, and that's really what we're looking for. You know, you're looking for the things that'll affect people. The whole trend on prostate cancer is not to treat the disease that won't affect people. That, you know, people come in, they say, oh, you know, there's something else is going to kill me anyway. I'm like, how do you know that?
You mean not to do surgery on the ones that are not
surgery or radiation or anything? You know, you just watch them closely. You do active surveillance. You check a PSA every 3 months. You do a biopsy every year. You see what's going on, and that way you can watch the pathology and make sure it's not becoming anything that's dangerous and it's not turning. If they just had one little core of cancer previously and now it's in 3 areas, that's something that you need to take care of. If it's, you know, and that's really the test. So the next, you know, and pretty much the MRI guidance with the URINEV is something that we're offering now also, and I have a picture of it also. So if you look at the images here, the top one is an ultrasound, and the bottom one is the MRI. And when we look at the two images, they're actually fused together. The radiologist marks the area on the MRI, and we can actually put that information into our ultrasound machine. So when we're doing the biopsy, we can watch a needle go through that red little dot, and that says, hey, there's a lesion here. We know what we're checking, we know what we're testing. We're not randomly just sampling the entire prostate. If you're a millimeter over to the left when you're doing it blind, there could be something there that you're missing, and this isn't, you know, and of course these aren't, you know, nothing's 100%, but at the same time it gives you a much better target. If you have a gun with 10 bullets, you want to put 6 of them in the area where where something's going on, and you can spread the other 4 around.
So the ultrasound,
makes it a little bit better.
So the ultrasound is the live image that you're looking at.
Absolutely.
And the technology superimposes the MRI on that.
Absolutely.
So you can know where to biopsy.
That's it. And
that's pretty cool.
It is pretty cool. These are fun toys, you know, and this is the new stuff that's coming out, you know, and it's something that has been available and it's been written about, and this is the the next generation of what's going on. This is for the people that have had multiple negative biopsies. You know, they've had a lot of issues with my PSA is going up. I'm not sure what to do. There's something there. We just can't find it.
So you don't do that on. It's not done on everybody for biopsy.
I mean, people could do whatever they want. You know, there's I don't think there's an extra charge for it. But the MRI probably costs something. But the fusion.
I see.
But if that's something that people say, hey, I want to get that on my first shot, then it is what it is. If you feel a nodule, you don't really need to do that. You know, you can, if there's a nodule there, you know where your fingers, you can feel where to put the needle. But if you're searching through the prostate, it's really only indicated for people that have had negative biopsies. Your insurance usually won't pay for it unless you've had a negative biopsy for the MRI part of it. And if you've had a negative one, can't find it, PSA is still high, let's make sure there's nothing else going on, that kind of situation. This is where this really comes into play.
It's getting better and better.
That's it. And hopefully, I don't know if it'll ever get to 100%, but we're trying to get as good as we can. Once, let's say we get biopsies back, let's say you do a blind biopsy and you get it back and it's negative. Pretty much now we have a test called Confirm MDX where you can try to you can ping the areas around where the needle is. So if the needle's here and there's something over here, it'll ping the area around and look for methylation in the tissues. And that tells us next time, if the PSA still goes up and like, all right, you need another biopsy, kind of gives you a roadmap of where to do some extras. Even on the tissue, let's say you get a tumor back and it comes back as a Gleason 6 or a Gleason 7, there are 3 tests available that we run on that tissue. One's called Oncotype DX, one's called Prolaris, and one is called Metamark or ProMark. And those 3 tell us, is this a low-grade tumor that's going to stay low-grade? Is this a low-grade tumor that is an aggressive one? One of the tests, the Prolaris, talks about mortality risks involved with the lesion. So when we take the tissue out, we can actually say, is this a bad one is going to be, is this something that now that is benign that is going to become bad, or is this something that is going to morph into something that is going to really be trouble and we really need to take care of it, or is it something that we just watch and we can just keep an eye on it for a long time? There's another test that we can actually run on the entire prostate when it's removed called Decipher. That one is run on the entire prostate specimen, and it tells us, does this person need radiation after prostate surgery or not? Is this somebody that needs the full kit and caboodle? Do they need to get surgery? Do they need to get radiation right afterwards? Will that increase their survival or not? And these are tests that we run on the tissues after we get them, and it guides us on what we really, what the next step is going to be in therapy. The question is how much do you trust the technology, and where is it headed?
Well, this is pretty amazing stuff. I mean, even in the time that we've been doing this show together, it's changed significantly.
Absolutely.
I mean, just random biopsying just seems so primitive now that you're
that's exactly right.
Showing us this.
If somebody had a
amazing.
kidney lesion, you wouldn't just start sticking needles into the kidney. You want to hit right where the spot is, and if you can do a biopsy, and that's the same thing now with the prostate.
Well, we really appreciate you coming, and we want you to come back again because I know you have more to teach us. Thanks a lot, Dr. Guttman.
Thank you.
Good evening. Good day.